Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a virtual partner for this event, and the focus of today's session is anesthetic management of trauma. Now, I would like to invite Dr. AL Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Stanley and Theney Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council member, President, and State Secretary of the ISA TamilNadu State Branch. To, pre- to proceed with the session, over to you, sir. Thank you.
Thank you very much. And now I welcome all of you for the 34th episode of Puthukkottai Bhudhan, the second edition. You may be knowing that Puthukkottai branch has conducted 3 years back 52 continuous webinars on every Wednesday. So this is second edition we are doing, and successfully we are going for the 34th. So we have to continue 18 more. So we are a little bit tensed up. But because of people like you, it was very easy for us to organize. And again, we have proved that Nari Shakti, I used to say the women power. All the four speakers are women. The advantage is the lady doctors first eroded the OG department 100%. Then they invaded pediatrics. Now they have completely abolished the men force in anesthesiology department, and they have come up very well, even in academic side as well as practical side. Usually we used to say they cannot take part in the ICU management, but all anesthesiologists are taking ICU management also, and now they are taking out of interest. That too, lady doctors are selecting anesthesiology as a matter of pride. So that I am happy to see this. And today we have the youngest faculty, Dr. Manimozhi, postgraduate from Chettinad Medical College. See, usually we want to have the postgraduate just to create and kindle interest in their mind so that they will become would-be teachers. That is the idea. So we are happy to welcome her, and she has completed her UG in Savida Medical College, and now she is doing her second year MD anesthesiology, and she is interested in so many activities. See, that is, she is interested in travel. We used to say in home that you are going around the city always, but she's putting it in a nice format. She's interested in travel. That means she's roaming here and there, and she has put it in travel. And see, she has put it very clearly. She's interested in learning new skills. I don't know what new skills she's going to learn, whether it is focus or ultrasound guided nerve block, or it is extracurricular new learning. I don't know, but she's interested in reading. Reading means not anesthesia text, I think. Reading novels, reading stories. So that sort of interest she has. So we should appreciate her enthusiasm to take part in this Puthukkottai Bhudhan webinar. So I congratulate her and best wishes for your bright future. And it will be followed by Dr. Indhumathi, who is also looking like a postgraduate. So she is an assistant professor in Chettinad Medical College. But see, she is another qualification she has, that is MBA from Annamalai University. So she's a good business manager, and the managing skills are very good with her. And she has learned so many things. That is good clinical practice training she has undergone, basic life support, advanced cardiac life support, and she's the instructor for that. And in addition, with her pediatric phase, she has been trained in pediatric advanced life support also. So all ICU courses she has covered, and she has won prizes, first and second prize in quiz programs conducted in Pondicherry. And the best thing is she has won the Excellence Award for doctors for bringing more patients under Ayushman scheme from Honorable Chief Minister of Puducherry. So we congratulate her and we welcome you, ma'am. And So when these people are postgraduate and assistant professor, the most skilled lady should be the professor, or else it is very difficult to control these people. So the professor we have is Dr. Merlin, and I think she may be weighing only 42 kg. But with that, she has finished her MBBS from Kilpark Medical College in the year 2004, and 2009 she has finished her MD from the prestigious Madras Medical College. She has won that World Anesthesia Day prize when conducted in Stanley, second prize, and she has won again when World Anesthesia Day is conducted in MMC. She won the third prize, and she has won the Best Teacher Award from Chettinad Medical College. Usually, anesthesiologists will not be given that award. They will not be considered as teachers by the management, and she has won the Best Teacher Award. At the same time, I want to say I was given the Best Teacher Award by the Dr. MGR Medical University, because they will never select anesthesiologists as a teacher. And because of that only, I have the passion again. But once it is recognized, we have to continue that. So she has won that. And she was an assistant professor in CMC Vellore. That is also another point, and she has become associate professor in 2018 to 21 in Chettinad, and now from 21 onwards, she is a professor. So again, she has undergone so many trainings, biostatistics, good clinical practice, research methodology, regional analgesia, clinical trials, and again, when her assistant is trained in BLS and ACLS, necessarily as a chief, she has also undergone the same training. So she's a good athlete. Actually, she's a good athlete. So when I say that she may be weighing 42 kg, the background is that she's an athlete and she has won 100-meter, 200-meter dash. But whenever a crisis comes, she will not run away. She will take part in that. When the point of sports, she will be a good runner. And again, she is interested in reading. And she has presented a paper in WFSA, World Federation Conference in Singapore, regarding this LMA and fast track for blind nasal intubations, blind intubations. And she has more than 10 publications to her credit. Now, the major point is when these three stalwarts lady doctors are participating, it is very difficult to control them, like people like me. So we have hired Dr. Lailu Mathews. She is a former HOD of Chettinad Medical College. So probably these people may be working under her for some time. So definitely, Madam can control. Madam has a vast expertise, more than 30 years of service in anesthesiology. And even after taking a retirement from Chettinad Medical College, her passion for education not stopped with that. So she has joined in Believers Church Medical College, Thiruvalla, Kerala. And recently they have celebrated Onam. So in that busy festive mood, after seeing the best festive mood, because even in TamilNadu, it was just like a fire, this Onam festival. So irrespective of caste, creed, religion, the Onam festival is so popular, and Madam has just witnessed. And when she's working in a believer's church, Madam, we are believing in your expertise in anesthesiology, and we hope you are going to give a good auditory treat in anesthesiology. All the four, I welcome and hand over the session to Dr. Lailu Mathews, moderator. Thank you, ma'am.
Thank you very much, sir, for the introduction. And I thank the organizers for giving me this opportunity to moderate this session. We have 3 lectures for today. The topics have been chosen very carefully. It's very useful. The first one starts with Suffer's airway, which is of historical importance and which has become, it has been not reinvented, but we have put into practice after COVID pandemic. Followed by the next topic is anesthetic management of blunt trauma abdomen. And the third one is anesthetic management of patients with cervical spine injury. So I'm sure that there is a lot to cover in these topics, and especially for the postgraduate students, it will be a very useful talk. And let's listen to all 3 of them. And towards the end, we'll have a discussion on the topics. So over to our first speaker on Suffer's airway. I welcome all of you to this meeting. So let's go ahead with the presentation.
Shall I proceed, ma'am?
Yeah, go ahead. Please start. Yeah.
Yes, ma'am. Good evening, all. My topic is on Safa's airway. I am Dr. Manimozhi, second year postgraduate. I am doing my PG in Chettinad Hospital and Research Institute. Safa's airway is a simple airway for first aid resuscitation. It refers to the devices or the techniques for maintaining a proper airway. For patients, developed airway developed by Peter Safar Joseph. Peter Safar Joseph is a pioneer cardiopulmonary resuscitation in the late 1950s by developing the ABCs, airway breathing circulation system, and advocating for mouth-to-mouth resuscitation, which formed the foundation of the modern CPR. His research documented in publications like ABCs of Resuscitation led to the Safar Center for Resuscitation research at the University of Pittsburgh, solidifying his legacy as the father of CPR. He introduced as a part of airway management in resuscitation. He bridged the gap between the basic and advanced airway tools. This airway is to facilitate mouth-to-mouth ventilation and basic airway management before advanced airway devices like LME and ET tubes were widely available. There are types of airways that suffer oropharyngeal airways. One is Saffar's airway, Goodell's airway, Berman's airway, and Waters airway and Brooks airway. My topic is on Saffar airways. I'll be talking about Saffar's airway first. It's a curved and S-shaped plastic airway device consisting of two Goodell's type airways shouldered together. This fits between the oral cavity and pharynx. It maintains the airway patency. It's a simple and lightweight, and it's reusable. It's specifically designed for resuscitation. It was originally made for chrome and later adapted into the plastic. Position how to direct the airway. It's a position the first position patient in the supine position, open the mouth using head tilt, chin lift, or jaw thrust, triple maneuver method, and then insert the airway with the curved end pointing upwards, rotate it 180 degree as it reaches the oropharynx, and ensure correct placement and patency. Then next is I'll be talking about other airways also. The Goodell's airways, it's most widely used oropharyngeal airway worldwide, made of rigid plastic with a halo channels. It's available in different sizes from 0 to 5, and it is color coding also. Functions, it prevents tongue fall and provides a channel for suctioning and ventilation. Then Berman's airway. It is made up of two parallel side channels with a central port. It's lightweight plastic airway tube. It advantages is it allows easily allows the suction catheter to pass through the side port. It causes less risk of biting compared to Goodell's. And then Waters airway. It is one of the earliest oropharyngeal airway used in the anesthesia. It's made of metal, stainless steel, or chrome-plated brace. It's a J-shaped curved airway which has its flange at its oral end to prevent slipping inside. The advantages is it's reusable, sterilizable, and it's very durable. Disadvantages being its metal, it did not allow it will cause injury to the lips and teeth and oral mucosa. It did not allow oral easy suctioning like modern Goodell airways. It's heavy, uncomfortable, and required careful handling. This is a Waters airway. Then Brooks airway. The Brooks airway is also made of metal. Is usually stainless steel or chrome plated. It has advantages like incorporated side opening, like fenestrations will be there to facilitate the air passage. The disadvantages is it lacked a dedicated suction channel, and it's difficult to clear the secretions. It causes oral trauma, dental injuries, and mucosal damages. The role of oropharyngeal airways, like Safar airways in anesthesia, is it's used during CPR for airway patency, and it serves as a rescue device when bag and mask ventilation is difficult. And it's used as a pre-anesthetic airway stabilization in emergency scenarios and a training tool for airway management in anesthesia residents. It's only for unconscious patient with absent gag reflex and may be used as a bridge before endotracheal intubation. It can be used for rescue breathing and used as a temporary airway adjuvant before advanced airway placement. and its advantages and limitations. It's easy to use, useful in pre-hospital emergencies, and prevents airway rescue obstructions and facilitate rescue breathing, and no special equipment required. So disadvantages is it not suitable for conscious patients, cannot protect airway from aspirations, and limited use in advanced airway management, and size selection is crucial for effectiveness, and it is superseded by the advanced LMA and advanced supragalactic airway devices nowadays. The contraindications of a surface airway, cannot be used in conscious or semi-conscious patients, and the patients presents with gag reflex, and patients with facial trauma with the risk of obstructions and severe oral injuries. Uh, Surface airway was with other compared with other oral pharyngeal airways. The suffer airways are similar has similar functions, but it suffer especially designed for resuscitations. Suffers was laryngeal mask airways. Laryngeal mask airways provides better seal, but aspiration protection is there in is there for laryngeal mask airways. And suffers was endotracheal tube. Endotracheal tube is a definitive and protects airway against aspirations. Suffers remain simple, low cost, and rapid options in emergencies. Thank you.
Thank you, Dr. Manimozhi.
Thank you. Thank you, ma'am.
I think we'll reserve the questions for the end. Or should
Okay,
we?
ma'am.
Yeah. So we'll go ahead with the next speaker.
Yes.
Anesthesia for
You
blunt
stop
trauma.
sharing, Dr. Manimozhi, stop sharing your screen.
Yes, sir.
Good evening, ma'am, and thank you so much, sir, for the kind introduction. Hi, I'm Dr. Indhumathi. Hi, I'm Dr. Indhumathi, working as a senior resident in Chettinad Hospital, Chennai. Now we are going to see about anesthetic management of blunt trauma in abdomen. Okay. Just we're going to brush up relevant anatomy of the abdomen, and we're going to understand how blunt trauma causes the organ injury and how to manage it initially based on ATLS protocol. Then we'll learn something how to manage it in perioperative period, and we discuss some organ specific challenges related to blunt trauma abdomen. So first, we all know abdomen lies between the thoracic cavity and the pelvic cavity. Here, so it itself is divided into anterior abdomen, back, and the flanks. The anterior abdomen is composed of superiorly the lower thoracic cage and inferiorly the inguinal ligament and the pelvic bones. It composed of only hollow organs like small bowels, and the posterior abdomen, that is the back, it extends from the tip of the scapula till the iliac bone. It extends laterally till the posterior axillary line, composed mainly the retroperitoneal structures like great vessels, aorta, inferior vena cava, bilateral kidneys, under vessels, most of the duodenum, rectum, and ascending and descending colons. The space between this anterior and the posterior axillary line is composed of flanks. Mostly the flanks and the back composed of muscular layers and the paraspinal muscles, which act as a partial protection against upending injuries. And the third one is pelvic cavity. We all know it composed of the bladder, urinary bladder, and the reproductive organs. So in abdomen itself, it is composed of peritoneal cavity and the retroperitoneal space. Any injury to any organs which will lead to accumulation of blood inside the peritoneal cavity, which will act as a reservoir wall for an enormous amount of blood collection that will become unnoticed, and patient may progress into worsening of hypotension and later hemorrhagic shock. The retroperitoneal space also serves the same. So, this denotes incidence of blunt trauma is approximately 69.78% worldwide, but mortality rate was 12.7% due to the undiagnosed and misinterpreted signs and symptoms of the blunt trauma. So, blunt trauma, how it causes injury? Due to the direct blow to the abdominal structures. It could be due to direct blow from a steering wheel of a car or a handlebars of the bicycle or a motorcycle, or it could be direct injury of the intruded roads, or it could be a compression injury due to dashboard crushing, which will lead to solid organ rupture like a liver injury and splenic injury, or it could be a deceleration force or shearing force. That is, if imagine if you're moving in a fast moving car and it suddenly stops, then your body has to come in an inertia position. For that, you move forward and backward. Our organs will do the same thing. The organs which are fixed and partially fixed, like mesentery, which is fixed into a vertebra, that will again have the forward and backward movements, which will lead to mesenteric avulsion and renal pedicle tear. And the injury to the organs can also due to the associated fractures like pelvic fracture, fractures due to the ribs, which can injure the spleen and the liver. So in the abdomen, we mostly encounter about solid organs injury, which could be liver, spleen, and kidney, or injury to the hollow organs like small bowels, large bowels, or the bladder, or it could be due to bone injuries. In all those things, the solid organ injury leads to the most incidents of death due to hemorrhagic shock. In case of hollow organ injury, like small bowel injury, the hemorrhage won't be that much, but patient may later present as peritonitis and will land up in septic shock. So how we are going to initially assess the case? First and foremost is catastrophic hemorrhage control. That is applying a constrictor band, or if it is in the pelvic cavity, then pelvic binder has to be applied. Whatever the hemorrhagic bleeding organ, that has to be compressed first. Then airway, then we move into normal assessment like airway, breathing, circulation. Airway, here that patient could be in polytrauma, so airway has to be managed, and the cervical stabilization has to be done either by cervical collar or by using the incident by the surrounding components. Breathing has to be stabilized from the nose till the alveoli, so that we should maintain a normal ventilation to the patient. We should also consider pneumothorax, hemothorax, or a diaphragmatic rupture, or abnormal breathing movements that has to be neglected. And circulation has to be maintained due to we already know that patient is more prone for hemorrhagic shock and septic shock. So shock assessment has to be done. Then he has to be loaded with adequate fluids like 30 ml per hour initially, 30 ml per kg initially, followed by we have to assess the hemodynamics, then move on to the correction. Then we should know about the GCS of the patient, and should rule out the intracranial bleed also. And we should adequately expose the patient from head to toe for visible bruises which can occur due to direct blow or a contusion from a seatbed marks. After all those initial surveys, ATLS protocol moves on to a proper blunt abdominal trauma protocol. That is, if the patient is hemodynamically unstable, we should right away do simultaneous FAST. FAST is nothing but focused assessment using an ultrasonography. If in that, in FAST, we usually see all the sacs, the Morrison's pouch and the rectouterine pouch, and in the splenorenal space. If fluid is found, then it denotes FAST is positive. That here you can see it is the liver parenchyma, and this is the kidney. The space between these two is filled with fluids, which is a hemoperitoneum, which denotes fast is positive, and the Morrison's pouch is the first thing which retains the collecting blood because it is more dependent part. If this is positive, then we should directly move into laparotomy. If it is negative, we can always evaluate afterwards after 30 minutes for the impending hemorrhages. If suppose you're in a setting where ultrasonography is not available and patient's hemodynamics also are not stable, then for that patient, you can go into diagnostic peritoneal lavage. In diagnostic peritoneal lavage, the surgeons will introduce more amount of NS, like 1 liter of fluids, and then they re-aspirate it. During aspiration, if it becomes positive for fecal matters or bile, then it denotes bowel perforation or biliary perforation. So they will straight away take it into the laparotomy. Or in the aspiration, if the blood comes, if it is more than 100 ml, that also signifies the hemoperitoneum. In that scenario also, we should move into laparotomy. If it is negative, then we can observe the patient for 24 hours and reassess. If suppose in the scenario where patient is hemodynamically stable and CT is available in the setting, in that setting, you should transfer the patient to CT, where you can determine whether patient is having pneumothorax or bowel perfusion or organ injury, and accordingly we can decide for surgery. If in a setting where CT is not available, in those settings also you can do fast or peritoneal lavage depending upon the availability of the instruments. So apart from fast, we also have CT scan. I already told you. So CT scan is done only in case of stable patient. It is more towards contrast enhanced CT. So we are going to introduce dye into the patient. So patient's renal parameters also be taken into account. Or we can do a diagnostic peritoneal lavage. This has not been practiced nowadays due to the availability of all the facilities, radiological facilities in the recent era. The other indications of laparotomy includes peritonitis. Peritonitis is nothing but just a clinical evidence of peritonitis. Rigidity and guarding it itself a sign for doing a laparotomy. Or you can find free air or in the retroperitoneal air or air in the or air in the abdominal cavity due to the rupture of hemidiaphragm. In those settings, which can be detected even in simple X-ray of the abdomen itself, in those cases also, you should directly go into laparotomy. Other indication include evisceration of the organs. What is going to be our main challenge? Our main challenge is going to be hypovolemia, and patient land up in shock. It is going to be a perfused shock, because unless until we are replenishing the large volume of blood, blood which is being lost, the hypovolemia cannot be corrected, and patient will land up in lactic acidosis, tachypnea, and the oxygen demand will be rising. That will lead to the lethal triad like acidosis, hypothermia, and coagulopathy. Apart from this, if patient is conscious that stress responses and pain, it again increases the catecholamine surge, which will again releases the inflammatory mediators, tachycardia. It again worsens the scenario. It also, we should have to prioritize which has to be dealt first in case of polytrauma or multiple injuries. What will be our preoperative consultation? First, we should take a proper history, depending upon, we should know properly about mechanism of how the injury has occurred, so that we should ruling out other organ injuries. And we all know here airway is difficult, not because of full stomach, but also the cervical instabilization, or patient can have upper airway edema or lung contusion, So ventilation has also become difficult for these patients. And also in most of the cases, we won't know the cervical spine status because we won't have time for the radiological investigations. So in those cases, practicing MILS, manual inline stabilization, during intubation will be more beneficial. And we have to secure, initially on coming to ER, we have to secure large bore IV lines. 16 gauge IV lines in bilateral bilateral limbs, and followed by central vein cannulation can be done for CVP monitoring and for the fluid resuscitation, and we should also secure the artery line. This securing artery line and central lines will become difficult on the background of onsetting hypotension, so that it is more appropriate to use USG guided accesses. Here, we initially know that for any trauma, initial resuscitation fluids would be crystalloid, either 0.9% NS or oral or a plasma light. We initially give boluses or load the patients with crystalloid only. Here, you can give a fluid therapy with a balanced salt solution, that is 6% HETA charge in a balanced salt solution which contains lactate, that is single lactate, approximately 100 to 150 ml of HETA charge mixed in a RL, which would have more intravascular expansion, so that we won't overload the patient much. And if HETA charge is not available, you're supposed to give more and more crystalloids, which will become difficult. So you can use either pressure bags for instilling the fluid, or rapid fluid infuses in a modern setting can be used. This availability of other instruments like inline fluid warmers can be beneficial in managing hypothermia, because we tend to give more fluid to the patients. And if the massive transfusion protocol is available in the blood bank itself, that would be very beneficial for the patient. And if availability of modern point of care devices like TEG and ROTAM, which will lead us to give a target-oriented infusions, that again reduces the transfusion-related complications like tracho, dilution, coagulopathy, everything. So this availability of modern instrument will make a huge difference in managing a blunt trauma case. Our main goals, depending on the scenario, would be to maintain hemodynamics. That is mean arterial pressure, to maintain organ perfusion. The permissible systolic BP has to be maintained 80 to 100 mmHg, and MAP could be maintained above ideally 65 mmHg, but it is permissible up to 55 mmHg. There is a controversial scenario regarding permissible hypotension versus deliberate hypotension in a polytrauma case. Permissible hypotension is nothing but you're correcting the hypotension of the patient, in which you're not over-correcting it. You're stopping it till you're reaching the upper limit of 80 mmHg in the systolic BP. Whereas in the normal scenario, you tend to overcorrect, or you give the fluids, overloads the fluid. Then during the intraoperative period, you will deliberately reduce the systolic BP to have deliberate hypotension, which is controversial to what we practice in the ER and in the OT. We should maintain the normothermia, already told you, because due to increased blood loss, patient is prone for hypothermia. So we should maintain it at least more than 35 degrees Celsius of temperature. And we always should avoid the secondary insults to the body. That is, we should avoid hypoxia, hypercapnia, acidosis, and anything which increases the airway pressures. And we should maintain the hemoglobin between 8 to 9 mmHg, if possible 10 mmHg also. Hematocrit has to be maintained between 25 to 30%. And we should maintain normal coagulation, like normal ATT, prothrombin time. And in this time, we should have more importance to the fluid management also. So in the intraoperative period, we already know patient is having difficult airway. and we can't induce the patient rapidly also, because intravenous injection is more prone for perfused hypotension in these patients. So we can have a balanced anesthesia. That is, you're going to reduce the induction doses, either induction doses, or you can use etomidate at the 0.2 to 0.3 mg per kg, or ketamine is preferred in this case. And you can have more opioids, fentanyl 2 mg per kg. We all know this full stomach state. So we are directly going to rapid sequence intubation only. In that also, if rocuronium is available instead of succinylcholine, that would be beneficial due to the risk of hyperkalemia with succinylcholine. The ventilation has to be maintained with lung protective measures, not only for the risk of pneumothorax, but also patient would have got polytrauma, so lung contusion may also can be that. And we should avoid high airway pressures, and even nitros has to be avoided. So we should maintain it in oxygen and air. With a balanced isoflurane or sevoflurane anesthesia has to be maintained. We can give opioid infusions to the patient with not exceeding the overdosages. And hemodynamics has to be titrated. Either is to be first initially the crystalloid and more of a blood and blood products to increase the intravascular volume and to replace the volume which has been lost due to blood. And if it is not controlling with the crystalloids and the blood, we should go into vasopressors. Vasopressors are mainly used as first line dopamine because it maintains the splanchnic circulation. And if upon that, we can add a antifibrinolytics, that is tranexamic acid 15 mg per kg, followed by infusion of the same can also be given. And again, temperature management is essential because it leads to DIC. Other some organ-specific management includes, in case of liver injury, we all know it's going to bleed a lot. So rapid transfusion is needed, and onsetting hypercalcemia, acidosis, that has to be corrected. So for every blood you transfused, at least 1 gram of calcium gluconate has to be transfused, and serial electrolytes has to be monitored in those cases. In case of splenic injury, it is not only the splenectomy, it also has a post-operative risk of going into sepsis. And we all know for a post-splenectomy patient, immunization is necessary. So that has to be taken care in case of splenic injury. And for bowel injury cases, I already told you, bowel is not a organ which bleeds profusely. But due to the contamination of fecal matters on air in the intraperitoneal space, it lands up in peritonitis. So antibiotic cover is necessary before the starting of surgery itself. In case of kidney injury, we should avoid nephrotoxic drug and maintain the urine output apart from other measures. So in case of special population, for example, if it happens to a pregnant woman, depending upon the weeks of gestation, we should take whether to abort the pregnancy or to continue the pregnancy. If pregnancy has been continued, left lateral tilt has to be given throughout the surgery, and fetal monitoring has to be done. And if it occurs in case of pediatrics, they are prone for rapid shocks. So fluid turnover has to be maintained in those cases. In case of elderly patients, apart from polytrauma, they also have impending comorbidities. So that will again worsen the scenario. And if most of the elderly patients, they have heart problems because of diabetes or hypertension, that again cannot hold the vast fluid shifts that we are providing. Then they have very fragile physiology, so they are more they can land up in hypoxia induced brain injuries. For the post-operative care, depending upon the type of surgery that was underwent, like it is an hepatectomy or a major organ resection surgeries, or or MTP was followed, in those cases, patient has to be monitored at least for 24 hours for full revival of their hemodynamics. For those patients without extubation, we should shift the patient to ICU and monitor ventilation and hemodynamics. If the patient is not on any inotropes and the ventilation is good, then only we are going to extubate the case. In ICU also, we should monitor all the forced things, like your temperature has to be monitored, urine output has to be monitored, ABGs has to be taken regularly, and the lactate level has to be monitored. Then hemoglobin has to be optimized for impending blood losses. In pain control, it is controversial to give epidural in these cases. So intravenous multimodal analgesia can be used, or else we can give blocks like quadratus lumborum blocks. In those patients who are in ICU monitoring, they are more prone for ARDS, because I already told you they will have more sympathetic surge in the beginning itself, and due to the injury they will release more inflammatory mediators also. Even though if the polytrauma doesn't have any lung injury, patient will end up in ARDS, bleeding, infection, and acute kidney injuries. So for early improvement of the patient and to reduce the morbidity and mortality, early nutrition has to be given, or we can use total parental nutrition also. And ERAS protocol has to be followed in these cases. So we discuss a case here. Here, a 30-year-old male who is just now had an RTA. His BP is 80/40 and he is hemodynamically unstable. He is having tachycardia and his fast is negative. He don't have any intraperitoneal hemorrhage. What you have done the airway fluids in sorry, it is not induction. You have done the initial management, like you have taken care of ABCDs. What will be your diagnosis for this patient, depending on what just we saw? Anyone? Okay. Here, depending on what just we saw, you can neglect the fast and diagnostic peritoneal lavage. Only rule out the intraperitoneal bleed. The retroperitoneal bleed, it has not been diagnosed with the fast or from the peritoneal lavages. So for those patients, either we should move into CCT or we can do a exploratory rhabdotomy. So this case would have got a retroperitoneal injury or a pelvic cavity injury. So that blood again accumulates, leading to hypotension. For those cases, blunt trauma abdomen with the pelvic fracture, first we should resuscitate the case. In the resuscitation period itself, you should give a constricting force, so that initially you should control the bleeding vessels. That in this case, you can give a pelvic binder. Again, we are going to give, we are doing a fast and DPL, which should become, if positive, then we are directly going to laparotomy, or if it is negative, then either we can do a angiography or a preperitoneal packing, just to stop the bleeding, just to manage the case temporarily, or we can give a endovascular balloon occlusion of the aorta, so that profuse bleeding is stopped. These are all initial management only. Ultimately, we should do a proper laparotomy if intraperitoneal bleed is present. If no intraperitoneal bleed, then retroperitoneal space has to be explored, or if injury is occurring due to the pelvic trauma, that pelvic fractures has to be fixed properly. So our takeaway messages: first and foremost, early ATLS based assessment has to be done, and fluid resuscitation has to be given in order to save lives. And the anesthesia has to be tailored depending upon the physiology of the patient, and not just for the surgery. Here, our importance is more towards damage control anesthesia rather than a more corrective surgery. if the patient is hemodynamically unstable, then also we are going to take the patient. We are not asking for pre-op optimization of the case. In this scenario, optimization itself is the surgery of the patient. There should be a teamwork with the trauma surgeons in the trauma care, critical and the critical care and the physician critical care, and us, and also with the teams in the blood banks and the persons who are transferring blood from the blood banks to the OT. These are my references. Thank you. Any questions?
Thank you, Dr. Indhumathi, for that presentation. You have covered anesthesia for blunt trauma abdomen. In general, as to ATLS protocol, that is something which is very, very important. Not to forget A, B, C, D, E. A for airway, breathing, circulation, disability, exposure, right? So this is something which is very, very important, not to forget. You might be called to emergency department of emergency medicine sometimes to have a look when a patient comes to the ER with an impending laparotomy or any other procedure. You might be called to the emergency room where you have to do a full assessment of the patient. So the idea here, what I would like to contribute, you have covered almost everything, but what I would like to contribute in this particular presentation is the severe solid organ injury, if at all it happens, like if it is injury to the high-grade injury to the spleen or to the liver, then the whole scenario changes. The patient will not be in a position to be shifted for a laparotomy. So that is where the interventional radiology has come in a big way. And even before that, you just mentioned one line on damage control anesthesia. So before we go into damage control anesthesia, it is all about damage control resuscitation and damage control surgery, followed by resuscitation in ICU, and then you go for a definitive surgery. Why I'm telling you this, we had a few cases like this where the trauma was very, very bad. We never thought we could get the patient back. So in such a situation, nobody would be willing to touch the patient. The surgeon will say, the anesthesiologist will say he's going to crash on the table. And he's so unstable. So here, what we are doing is, it is an abbreviated surgery, they call it. That is, just do the minimum and come out. Don't have to do any corrective surgery or reconstructive surgery. That is where your whole idea, the whole ATLS protocol, concentrate on what is most important at that point of time, life-saving procedure. And you had mentioned correctly the lethal triad. What we are trying to avoid is acidosis, coagulopathy, and hypothermia. So that is where your restricted fluid, you mentioned something about the permissive hypotension. We do practice that because giving too much of fluids, again, it sets a trigger for all the coagulation problems and things like that. So you have to give blood products. FFP is considered to be the most useful, but you can give blood products. So you replace the blood loss with blood rather than giving fluids. So in effect, we are buying time for a more definitive surgery. So that is the whole idea about. So once you have kind of stabilized by doing the all the ATLS and all those measures, the temporary measures, that is, it could be either, as you had mentioned, packing the abdomen or reducing the blood loss or whatever is required, because the patient is not fit for an open surgery as such. Yet we have to do it. He might be intubated at that time. You might shift him to the theater. All that is there. So how does, once this damage control surgery is done, we don't close the abdomen. It will be a huge incision starting from, it's a laparotomy starting from ciphisternum to pubic symphysis. The abdomen will be left open and patient will be on post-operative ventilation. So you have to wait for 24 to 48 hours for the surgeon and all the other multidisciplinary team to reassess the patient and go for a definitive surgery. So this is something I'm talking about, very severe injury. I'm not talking about the what you had mentioned. This is just an add-on to what you have presented. And a bit on interventional radiology. I was quite surprised to see that how interventional radiology has developed in the last few years. And it's quite amazing. We would wonder what is the IR team going to do in a blunt trauma abdomen when there is so much of solid organ injury. But they do a wonderful job. So we are just buying time so that, or even control the hemorrhage. They do well later on. So we need to know a bit about what kind of anesthesia will you do for us. So The procedures are, one is the transcatheter arterial embolization. Even if it's an abdominal injury, they can do an arterial embolization and stabilize the patient. And once the bleeding is stopped, the patient stabilizes. The next thing is RIBOA, the resuscitable endovascular occlusion of the aorta. So that is, if you have a cardiovascular team that is present around the clock, this is another procedure which can be done. So all these are life-saving measures. And once you have done it, reassess the patient. That is again very important as part of ATLS. Always reassess the patient. Keep watching how the patient is doing. And in addition to that, all what you have mentioned holds true. So that is how we have to go about it. So the therapeutic embolization, so life-saving hemostasis, then organ preservation and bridging to definitive therapy. So that is for high-end, high-grade solid organ injury. Where there is, and these interventional procedures are useful when the patient is not unstable. The patient is kind of stable, like the scenario you mentioned before, but highly unstable. Now they say even if there is intraperitoneal bleeding, you can go ahead with that, with the procedure. But the main thing is take care of what is important at that time, stabilize the patient, get him out of the real catastrophic situation and go ahead with that. And not to forget the lethal triad. So at any cost, avoid acidosis, give warm fluids so that hypothermia doesn't happen, and prevent coagulopathy. Rather than addressing the problem that has happened, it's better to avoid or prevent these things from happening. So it was a good presentation. You have covered almost everything. I just wanted to add these few points. Any questions? I couldn't find any questions in the Yeah. So if that is done, we can go. Thank you, Dr. Indhumathi. We can go to the next speaker, Dr. Merlin Shalini Ruth. She'll be presenting anesthesia for spinal cord, cervical spine injury. Over to Dr. Merlin.
Good evening, one and all. My heartfelt gratitude to the ISA President-elect, Professor Dr. Meenakshi Sundaram, for giving me this opportunity. And I'm delighted also to have Professor Dr. Lailu Mathews as the moderator.
Thank you, Merlin. It's nice to see you.
Yeah. So my topic for today is anesthetic management in a cervical spine injury patient. So the outline I would be going through is we would look at the patterns of injury and what are the systemic concerns in a cervical spine injury, intra-op management, including airway management and post-operative management. So the cervical spine injury, the incidence of trauma is 0.9 to 3%. And out of which 50% of the cervical spine injuries will have head injury also. So what are the causes of cervical spine injury? It could be trauma or it could be a trivial trauma. So when you consider trivial trauma, degenerative causes like rheumatoid arthritis or patients having collagen defect like Down syndrome and Ehlers-Danlos syndrome, and those who are having infections and tumors, even a trivial trauma will cause cervical spine injury. And the result of such an injury can be a bony damage or a ligament damage. A bony damage will result in a fracture, which could be stable or unstable. And depending on the site of fracture, it could be the occipitocervical or it could be the lower vertebra, which is termed as subaxial. And when it is ligamentous, then it can cause instability like atlanto-occipital level or atlanto-axial level. So the pattern of injury could be at the nerve root level or the cervical spinal cord itself. So the nerve root we can always identify through a radicular pain and a focal neurological deficit. But the cervical spinal cord injury will have definitive syndromes. So I have given a cross-section of the cervical spine where you can see the below one will be the anterior and the above one will be the posterior. And in the posterior part, you would find the dorsal column, which carries the fine touch proprioception and vibration. And the anterolateral column will carry the motor tract, which is the spinothalamic, the spinothalamic carries the pain and temperature, and the corticospinal is the motor tract. So both of these you find in the anterolateral compartment. Okay. So when it is a central cord syndrome, the motor will be affected and less of sensory, and the proprioception and the fine touch will be preserved. The dorsal column will not be touched. And in an anterior cord syndrome, the injured part will be both motor and sensory of both sides, sparing the dorsal column. So these are the patterns which you will encounter. So what are the systemic concerns when you have a spinal cord injury patient? So the systemic concerns would be the spinal shock, the cardiovascular complications, which could be a neurogenic shock, arrhythmia, autonomic dysreflexia, or a DVT, deep vein thrombosis. It could be pulmonary complications or a gastrointestinal complication, electrolyte imbalance, urological problems, and hypothermia. So we will deal with it one by one. So what is spinal shock? A spinal shock is an altered physiological state that can occur immediately after a spinal cord injury, and it is manifested by loss of spinal cord function caudal to the level of injury. And it is manifested as flaccid paralysis, anesthesia, absent bowel and bladder control, loss of reflexes, and it lasts days to weeks. Coming to the cardiovascular complications, the foremost importance is neurogenic shock. The neurogenic shock sets in within 30 minutes, and it can usually last up to 2 weeks, and it can last even up to 6 weeks. And that is because of an altered regulation of autonomic cardiovascular function. The spinal cord disrupts the descending sympathetic pathways. So there is an impaired sympathetic tone, which causes decreased vascular resistance in the large vascular beds, leading to increased venous capacitance and decreased venous rhythm. All this together will cause hypotension. But whereas on the other side, you see that the vagal tone is unopposed from the higher centers. And this will result in bradycardia or bradyarrhythmia or even heart block. And because of the predominance of parasympathetic system, you will have hypotension and bradycardia. So here we see the difference between a spinal shock and a neurogenic shock. Spinal shock is just the motor paralysis without any hemodynamic component, but whereas the neurogenic shock has the motor component, the autonomic component, and hypotension. And it starts immediately after the injury, whereas the spinal shock takes few days to settle. So the other cardiovascular complication is arrhythmia. So if you take bradycardia, most of the patients, almost all of the patients will have a resting heart rate of less than 60. And in 70% of the patients, the resting heart rate will be less than 45. And this is because of the autonomic imbalance, and it peaks on day 4 and it takes 6 weeks to resolve. So what is the solution for us here when anesthetizing? Atropine or preoperative pacing. The patients can also develop heart block or supraventricular tachycardia, ventricular tachycardia, even cardiac arrest has been reported. Now, what is autonomic dysreflexia? Now, this is usually seen in chronic spinal cord injury patients, but sometimes it can happen in acute injuries also, and it happens for any spinal cord injury above the level of T6. Okay, so if there is going to be a stimulus of a somatic pain, or an abdominal distension, or fecal impaction, or a bladder distension, it is going to trigger a hypertensive response where there is an increase in the systolic BP of greater than 20% with bradycardia and arrhythmia associated with flushing, sweating, headache, and blood issue. It is going to be terrible to manage. So only treatment is immediate removal of the stimulus. If it is fecal impaction, remove it. If it is distended bladder, catheterize. If it is pain, stop stimulating that region. Give pain relief. If at the extreme, you can use a vasodilator. So the pulmonary complications. So when there is a cervical cord injury and C3 to C5 or a little lesser than that, all these are affected, sympathectomy happens. So there is no sympathetic connection, influence into the sympathetic centers. So this can cause bronchospasm and increased pulmonary secretions. And these secretions will accumulate and will not be cleared. And the respiratory muscles, the diaphragm, and the accessory muscles, the external intercostals, all are going to be affected. And the patient will not be able to take a full vital capacity, will not be able to cough and clear the excretions. And added to it, there is going to be a spinal cord edema, which is going to ascend and worsen the existing level of disturbance. And that could be direct chest trauma with patients having cardiac tamponade or contusions. And all these can result in respiratory failure. All these will result in atelectasis, poor clearance of secretions, mucus plugging, which leads to pneumonia, and the patient will go for respiratory failure and will become ventilator dependent. Okay, so how do we do a pre-op assessment when this patient comes to us for surgery? So we need to do a history, good history. But of course, as anesthetists, we come in the later stage when the orthopedician and the neurosurgeon would have done a thorough analysis, analyzing the type of injury, which level is affected to make the decision of surgery, and all the patterns of injury, the mode of injury, the mode of force is all studied. Okay, so that will indicate the type of injury. And our role still exists in doing a thorough physical examination. Don't forget the general examination, having a good hold on how the vitals go and how is the cardiovascular system, anything added on to the existing neurological deficit, how is the respiratory system, and the neurological assessment. And for us to be aware, the neurosurgeons would give the injury status as a Asia grading, Asia A, Asia B. I put it up for us to understand what level of injury the patient is. And to confound it, all of it is what we have to understand is when the patient is in spinal shock, he would be a Asia A. There is scope for improvement. And as anesthetists, we need to ensure that we do not cause further damage to the spinal cord. Okay, so any trauma patient comes to us, the cervical spine has to be clear. We have certain rules, the Canadian C-spine rules, followed by Canada, and the Nexus criteria, which helps us to avoid unnecessary radiograms. But being anesthetists, we need a definite clearance from the neurosurgeon for any road traffic accident that the cervical spine is cleared. So what are the investigations they would be looking at is X-rays, which would be inflection and extension lateral view, or an anterior-posterior view, open mouth, a CT and an MRI. So an X-ray and a CT is a must, or an X-ray and an MRI helps us to look at more of the soft tissues. So just for you to know, like what we look at an X-ray. So we need to look at the continuity of the lines. There are certain lines which tell that there is no instability. The fracture has not caused instability because it is very important in shifting the patient, in positioning the patient for face mask and for intubation. So we need to be aware of the four lines. The green one is the anterior vertebral line, and the pink one is the posterior vertebral line, which passes through the posterior portion of the body of the vertebra. Then you have the spinolaminar line, which passes through the lamina, and then through the spinous process, which is a spinous line. And all these lines will have to form a smooth curve. And when that curve is lost, you know that the cervical spine is unstable, and the patient, you should be extremely careful. And just to add on about this atlantoaxial instability, which we would encounter more often in non-traumatic or mild traumatic disorders, such as in Down syndrome, when an adult Down syndrome patient comes to us for surgery, or a prolonged rheumatoid arthritis patient coming to us for surgery. We need to know whether that patient is having atlantoaxial instability. So how do we find that out? This is a X-ray lateral view. And this to my right will be the anterior, to my left will be the posterior. And in the anterior part, this is the atlas, which is the first vertebra, and this is the dens of the second vertebra, the axis. And we need to look at the distance between the posterior border of the anterior arch of the atlas to the dens. This is called atlanto-dens interval. And anything above 10 millimeters, it requires surgery. And you should be very careful not to touch the patient. If at all you want to intubate, it should be with nil movement, which means it should be a awake, flexible, scopy intubation. And the other thing which is very important for us with regarding to this instability is the space available for cord, SAC. That is what is very important. And here the space available for the cord is between the posterior part of the dens to the posterior atlantodental membrane. And this is where the spinal cord, the cervical cord is sitting. So when the space available for the cord becomes less than 14 millimeters, you know, any moment is going to come, any movement is going to compress the cord, and it is going to worsen any injury which is already there, and it is going to trigger a vicious cycle of secondary damage. So what is the choice of anesthesia? So patient comes to you in acute stage, usually for a cervical spine stabilization to prevent further injury. It has to be a GA. Or if the patient comes later on for other injuries, you can give regional anesthesia as well. So what are the components of our anesthetic technique? So we start with monitoring. So we should have a standard monitoring of a pulse oximeter, of an ECG, NIBP, ETCO2, oxygen analyzer, temperature. And I would insist, especially in acute spinal cord injury patients, you should have an invasive arterial BP. Why invasive arterial BP? As I said, patients will go for neurogenic shock. They are highly labile, highly sensitive to any anesthetic agent, and we need to monitor beat by beat BP and have an invasive arterial BP, and make sure that you have two white bone lines, a 14 or a 16 gauge line as venous access, so you can expect heavy blood clots. Do you pre-medicate? Usually you don't do, because already the respiration is affected. But in case if it's a lower cervical spine and patient is very anxious, you can manage with a small amount of midazolam, say 1 mg as pre-medication. And pre-oxygenation, you have to ensure that you pre-oxygenate the patient. A head up would always be better for adequate pre-oxygenation in this patient who do not have adequate vital capacity. But again, keep in mind, a head up will bring down the BP drastically because of this patient is already in neurogenic shock. So it's a give and take. You can do pre-oxygenation with supine and have high frequency nasal oxygen also throughout when you're making the intubation attempt. Okay, and then how do we go about induction? Yes, we can use our thiopentone, propofol, etomidate, anything you can use. But remember that these patients are already bradycardic, already having hypotension because of sympathectomy. And if it has been a few days or a couple of weeks old injury, you can be sure that there is a lot of muscle loss, and because of which the central volume of distribution is going to be small, and any drug that you give, it is going to cause a drastic fall in BP. So what you should do, give pre-operative, pre-induction atropine 0.4 mg. If the patient is bradycardic, definitely give it. And probably start an infusion of inotril. It could be noradrenaline, or as I would show you in the following slides, the options which are available. And what about the muscle relaxant that you could use? Remember that scolding should be avoided after 48 hours from day 3 to 9 months because it can cause severe hyperkalemia leading to cardiac arrest on table. Normal healthy patients, it increases by 0.5 milliequivalents per liter transiently. But in cervical spine injury, it's a severe hyperkalemia which is caused and which is dreadful. So next, the most important is the airway management. So we have a patient here who's having limited neck extension, or the patient is immobilized and the patient has multiple injuries like facial injuries, and there's going to be retropharyngeal hemorrhage and edema inside, which you can identify only through the radiographs. All this is going to lead to a difficult airway patient for you to handle. So how do you do? The patient is already immobilized with a cervical collar. Yes, of course, you can remove the anterior part of the cervical collar. So you have many things to do: a manual inline stabilization, a rapid sequence intubation, direct laryngoscopy, video laryngoscopy, laryngeal mask airway, flexible scope intubation. So many options. Do we do everything in one patient? What are the things which we do in one patient? So let's go through. So the rapid sequence intubation is reserved for emergency cases. But in cervical spine injury, one of the gastrointestinal systemic effect is delayed gastric emptying and gastric dilatation, gastric perforation, and hemorrhage. All these are there. So you consider a cervical spine injury as a full stomach. So that's when you give the cricoid pressure. So where do you give? Over the cricoid, it's a perpendicular force of 5 newtons, which has to be given. And it has to be done by trained people. And remember that you can displace an already existing fracture and worsen the injury. And if there's any difficulty in intubation, you have to remove. There's no 100% evidence that it has to be done to prevent regurgitation. Okay? So you are clear that you can go ahead with RSI, but if you have any difficulty, please remove it. Then what is this manual inline stabilization? So you can do it 2 ways. If you're standing at the head end, this is how it would be. So your palm will be grasping the occiput of the fingertips at the mastoid process. When another person is intubating, you will be at the side of the patient. And again, there it will be like the other way around. Your fingertips will be holding the occiput and the palm will be holding the mastoid process. So what should you do? You will hold it tightly and not give traction. All that you have to do is to give a counter force. Okay. So when you do that, it is definitely going to increase the force which is required for laryngoscopy. As you can see here, the anterior collar has to be removed. Okay. So I would like you to look at the various movements of the cervical spine. So we are looking at 2 aspects. One is the occipitocervical, which is like CO is occiput to C2. These are the important group of movements, and below the C2 is another set of movements. Okay, so if you look at the occipitocervical junction, either way, it's either flexion or extension is around 10 to 15 degrees. And if you stay, even in a video laryngoscopy, they have seen that they produce almost 10 degree flexion or extension at that joint. And if it is C1 to C2 level, the normal is 8 to 10. Video laryngoscopy reduces it a little bit more. Direct laryngoscopy, it can go even up to 19 degrees. So when you say it's 19 degree flexion or 19 degree extension, it is to the extreme of causing instability. And the lower spine are not affected that much. You can see that when they are not affected that much by the video laryngoscopy. So what is the conclusion of this is video laryngoscopy does eliminate the lower spine movements, but the upper cervical vertebra movements, it reduces only to a mild degree. I want you to take a look at this image where when we intubate, see, look here, that you notice that it's severe extension of head or neck when you put the scope into the mouth and lift. So that much of movement is happening, which is not reduced to a greater extent through the video laryngoscope, only for the lower cervical spine. So now, what is our solution for airway management? Yes, we have a solution. So when we do mask ventilation, remember to give manual inline stabilization. The insert airway so that the manipulations are less. If at all any manipulations, it is a forward jaw thrust. And if the injury is at the occiput or atlas axis level with instability, the only option for us is awake flexible scopy intubation, nothing else, so that we do not produce any movement at all. The other places of injury, we can do video laryngoscopy, but still a manual inline stabilization with or without that. And some situations, depending on the skill of the anesthetist, we can do a direct laryngoscopy using a bougie to intubate instead of giving pressure. So all these depends upon the equipment which is available, the skill of the anesthetist in using the equipment, and the difficulty that they are encountering in the patient. So apart from the instability at the occipito-cervical level, where only awake flexible intubation has to be done, the other injuries you can manage with video laryngoscope, because ASA closed claims has said that there's no claims for neurological injury post-intubation or post-face mask ventilation. Since clinically we have not seen, we can use any of the methods. But what we have to remember is the most hazardous position for the cervical spine is when the patient is positioned for the surgery. As anesthetist, we should remember and actively interact with the surgeon in ensuring that the position is safe. So how do we maintain anesthesia? So we can go for intraoperative neurophysiological monitoring. So neurophysiological monitoring, what are the options for us is somatosensory evoked potential. So what happens is in the peripheral nerve stimulation area, some tickling, some stimulation will be given, and some electrodes will be kept on the somatosensory cortex, or on the scalp over the somatosensory cortex, looking for potentials. Okay. What are evoked potentials is there is a cranial stimulation, and we are looking for motor movements in the muscles. The direct waves are there, and then the spontaneous and triggered electromyography. So these are from the specific muscle groups where electromyography is got spontaneously. It's for selective root function. And when they are putting the pedicle screws for fixation, if it is compressing on the cord, you will get a triggered electromyograph, which indicates that they have to change their plan and undo what they have done. Okay. So how should our anesthesia be? When it is a direct wave, like due to direct stimulation of the cord, anesthetic agents will not affect it at all. And if it is a spontaneous or triggered electromyograph, as you know, it's a myograph. No relaxant should be used when you're doing that, obviously, because we are looking for muscle movement. And SSEP, you can use volatile, but if the patient is having pre-existing sensory deficits, then it will be very sensitive to volatiles. So it is better to go for TIVA, total intravenous anesthesia. And when you're doing motor evoked potentials, you should go for TIVA only without any muscle relaxants. So the best way to go for it will be a propofol infusion. We can manage to have less than 0.5 MAC of sevoflurane. Why do we keep MAC? Volatile is because there will not be any individual variation. There will be a consistent flow of volatiles, which help us to reduce the dose of propofol, and of course, it will reduce affecting the hemodynamic management. So what is our hemodynamic goal for this patient? So we look at the spinal cord perfusion pressure. We have to keep the mean arterial pressure a lower limit of 75 to 80 and not more than 90. The spinal cord perfusion pressure is mean arterial pressure minus cerebral fluid pressure. Okay, so how do we go about it? We can give fluids, and it should be a balanced crystalloid fluid. When you give fluids, what you have to remember is the patient is in neurogenic shock. So you should not rush fluids. You look at dynamic indices of fluid responsiveness. You look at static indices and make a decision. If you're not able to do all that because you have an intraarterial BP, you look at the pulse pressure variation and keep it less than 13%. That is enough. But fluids alone should not be given, remembering that fluids will result in pulmonary edema and we will not be able to extubate the patient, which is already complicated by respiratory failure. So what you should do, you should add on inotropes. Okay. And when there is blood loss, you give blood for blood. So reduce the balanced crystalloids, give blood and inotropes. Okay, so what are the inotropes that you may use? So these are the doses that are used in the OR. The doses that are used in the ICU are different. These are the doses which are used in the OR. Phenylephrine also you can use, but since they are mostly bradycardic, we would rather go for norepinephrine in these patients, and it is at doses of 0.01 to 0.3 mics per kg per minute. Even epinephrine can be given. Look at the doses which you are giving. If you want a vasopressor dose, then it has to be at 0.1, more than 0.1 to 1 mic per kg per minute. If you want more of an inotropic effect, then you go a little lower on it, less than 0.1 mic per kg per minute. Know what your dose you're giving and what it can do to the patient. So vasopressin also can be used at the doses which are given for you to refer. So next is temperature management. Temperature management is very important. These patients have sensory dysregulation of the thermoregulatory centers. They have a loss of sympathetic tone and vasodilatation below the level of injury, and there's loss of sweating. So on one side, there's loss of heat. On one side, there's heat retention. So it's always a balance that you have to maintain. You just cannot put the blower at the forced air warmer at the high flow and just go away. But you have to balance that the patient does not become hypothermic also. You should look at it, look at the positioning. Remember that pressure points have to be cushioned. If you don't cushion them, they become pressure ulcers, and that will stimulate the autonomic reflexia, which is going to be very horrible for the patient and for you as well. Okay. So what about the emergence when the patient surgery is over and you reverse, you extubate or not, when to extubate? So you should have an anesthesia depth monitor because all the 4 limbs are not moving. You should have a TOF monitor. You can look at the facial nerve. Even if all the 4 limbs are not moving, you need all those accessories. And remember to give good pain relief. Plan for post-operative pain relief also. It should be a multimodal approach. Remember that chronic pain is present in 25 to 95% of cervical spine injuries. Talking about this, whether to extubate the patient or not depends on the level of the surgery. So if it is a lower spine, cervical spine, like C6 to C8, the diaphragm is intact. These patients will not be having much of a problem except for the abdominal muscles. So they can be extubated safely and be watched out vigorously, these patients. But the patients who are at the level of injury having C1 to C3, sure, everything is gone. The diaphragm, the intercostals, everything is gone. They definitely need ventilatory support. You have no doubt about it. But what about the patients who are having injury at C3 to C5 level, or say C4 to C6 level? And these patients, what you have to understand is, at that moment, they might be ventilating well, but the spinal cord edema, because of the secondary damage, it increases slowly, and they will develop respiratory failure within 1 week. So you should watch out for that. So they will need respiratory support for some time before you discontinue it, say for at least 1 to 2 weeks. So you should be very careful about this group of patients when you want to extubate. Take your time, keep the tube, avoid tracheostomy because patients can come out, but then do not extubate. Have caution when you want to extubate, because intubating again is going to be difficult, because after surgery the cervical spine is going to be fixed and you will not be able to do anything after that. So these are the things I would like to cover, and here I end my talk.
Well, thank you, Dr. Merlin, for that wonderful talk on cervical spine injury. You have covered almost everything very beautifully, very nice representation. You started with the anatomy and all the pathophysiology associated with that. What are the challenges we face as anesthesiologists when we come across a patient with spinal cord injury? The changes that happen above the lesion, below the lesion, all that you have very nicely covered, and how to maintain the hemodynamics, because autonomic dysfunction is something which is very, very important, and we have to be aware of all these changes that happen, and timely intervention is required. So our treatment or our intervention starts right from the time the patient comes to emergency, and even in ICU, we are called many times to address these patients. You might see these patients all right. You might think, oh, he's okay. But within no time, you find that the patient has deteriorated or he has sustained bradycardia, cardiac arrest, etc. So that is how dramatic these patients can present with. So that is the reason it is such an important topic, and we need to be aware. Every movement or every second matters, and how we even shift the patient or how we move, how the positioning, everything is so important. And that is why so much importance is given to MILS, a manual inline stabilization during laryngoscopy. And you had mentioned nicely about the angulation, like how the changes that happen during our conventional laryngoscopy and video laryngoscopy. And one suggestion, even a McCoy blade to some extent can help in visualizing, because we need not, no movement is allowed. It's only the jaw thrust that is allowed in these patients. So intubation is has to be done very carefully. And of course, awake fiber optic intubation remains the method of the procedure, the choice of intubation or choice of, securing the airway. And hemodynamic, again, monitoring. You have mentioned about the neurophysiological monitoring by SSEP and motor evoked potential, all those things. So that was also covered very well. I wish there were more participants to listen to this very nice lecture. Autonomic dysreflexia, that is something which we all have to be careful. Like, we have to be aware of all these things. It might sound very simple. No, it is just some pilomotor, pseudomotor, all those changes that happen. But again, the loss of sweating, heat retention, all these are something which has to be addressed. And so that way, it is a very challenging situation for the anesthesiologist. At the same time, by careful, precaution, by taking, being very careful, like taking all the precautionary measures, we can come out with a very successful anesthetic management and outcome. And the management doesn't end there; it continues to the post-operative period, where that is why post-operative ventilation is so important in these patients. Should never be in a hurry to extubate these patients, because even spinal cord edema, that itself can cause later on. Like, you might think that the patient is all right, in a hurry to extubate, but once it's extubated and there is edema or even the injury itself, that can also cause problems. So as you had shown in the last table, like continuing ventilation, how long it should be. But there are various parameters to be monitored. Accordingly, we can decide on how long the ventilation should continue. And not forgetting the other parameters like to be monitored, temperature, the urine output, everything has to be taken care of in that. So it is a holistic approach that is required for these patients. And during anesthesia, the most important thing is preservation of the maintaining the spinal cord perfusion pressure. That is why it's important to maintain the blood pressure. At no point of time should there be any ischemia or any hypoperfusion of the spinal cord, because it will not tolerate any hypoperfusion. So that adds on to the morbidity of the patient. So our anesthetic management should be tailored in such a way that the spinal cord perfusion and the hemodynamics, all that is taken care of well. And of course, airway, already you have mentioned how to secure the airway. So that was an excellent talk. Very nice to hear you talk. Almost everything was covered. So it's really good. There are no questions in the chat box. So
Yes, ma'am.
Yeah.
So actually, ma'am, if there are no questions, we used to say two things. One, the participants may not be knowing anything, or they fully aware of everything. So now it is very clear that they have sensitized everyone with their vast knowledge. Everybody was elaborate, and it was on time also. 7:30 we want to cover. If there are no questions, we can take it forward to conclude the session. If you want to pass any concluding remarks, madam, you can give up remarks.
I didn't give any remarks on the first speaker. Initially, I thought of reserving all questions to the end, but I thought these are very good topics which need discussion soon after the presentation. So we'll just go back to Dr. Manimozhi, who had given a talk on Suffer's airway. So she had mentioned about Peter Suffer, who had, so I had mentioned it at the time of introducing the speaker. It's about Suffer airway. This is of historical importance. I remember reading this in Dosh and Dosh, all the pictures, all the various types of airways. But it came in a big way during the COVID pandemic, because mouth-to-mouth resuscitation, that is something which is where nobody would want to do that. There is contamination, and especially when it is a highly infective, the pandemic was on. Nobody wanted to do this. That was one thing that that people would hesitate to do, give a mouth-to-mouth respiration. So this is where Suffer Airway came to rescue. And there was a company who had made, it's actually two Goodell Airway put together, soldered together. So one side goes to the provider, the person who resuscitates the patient. The other one is just inserted like an oropharyngeal airway. And it's called, it is mouth to pipe, so that the provider the airway doesn't get contaminated. There is no direct contact with the patient. So that is where it actually came into practice. And there is a company which has, I just saw the name of it. It has a PVC film also. So the patient, if you go to the net, you'll find that it has a one end goes to the provider who blows into the patient's mouth, and the other end goes as a oropharyngeal airway to the patient's oral cavity. So that is how we provide mouth to mouth or mouth pipe respiration. So this is part of barrier resuscitation, you call it, so that the provider doesn't get exposed to any of these contaminants or any infective things, the contamination is avoided, and the provider is safe by using this. So it's good that you brought we could discuss on this particular equipment, which is kind of nobody will bother to remember all this, though these were the initial airways that were available. So it was a good presentation. Thank you very much. I thank all the speakers for their excellent presentation, and thanking the organizing committee once again for giving me this opportunity to moderate the session. Thank you all.
Thank you.
Thank you very much, madam. So as a formal vote of thanks, I have to say, today I'm very happy, and I am the odd man out. When I am taking the screenshot, I have seen really the word odd man out. That exactly matches me. And I'm very happy to see the woman power, that too in trauma. And Dr. Manimozhi was very clear about, we want her to talk on Safar's airway. She has covered all the airways. But I think she is going to catch the flight now, immediately. So the pace in which I think the runner is the professor, Dr. Merlin. But the way in which she ran, I could not even imagine why she is running so fast. But anyway, the tempo will keep her alive, and she will succeed in her future. So this has to be taken as a first step. I thank you very much, Dr. Manimozhi, for your energetic participation. And it was really followed by Dr. Indhumathi, who has covered extensively about blood rich abdomen. See, it is really a recap we were enjoying, and she has, even though she has covered wide coverage, she has covered a special population also, pregnancy, elderly, and pediatric. So that is a good thing. But the key takeaway she has given, I liked very much. See, no preoperative optimization is required. That means you should not delay, because so many postgraduates, even if it is a trauma, BP of 80, 50, sometimes they will try to improve the BP and post the case again for assessment. But she has given that clear message. So I thank you very much. And as such, Dr. Merlin, see what a methodical presentation, how we can ask a doubt. She started straight from the trauma, cervical trauma, that too with a colorful picture of cervical spine, even the lines, even line by line, she was giving all complications about the CVS complication, pulmonary complication. And the thing is, more than the colorful photograph, at the end, she was talking about monitors, post-operative follow-up, and she has even mentioned when tracheostomy is needed. So how you can ask a doubt? It is a complete coverage. I can ask only one doubt. How you have prepared the entire lecture and you have covered within 30 minutes. That is the only one doubt I can ask. How it is possible to give everything in? It is not a condensed format. It is an elaborate format. It is not a capsule. It is a syrup, a bottle full. And even when you are talking so much, I was wondering what the moderator is going to do. But madam has really proved that she is your former HOD. What a excellent moderation and presentation from her. See, madam has given clear-cut ideas in trauma. I was very happy people have to follow it. See, avoid acidosis. She has mentioned avoid acidosis, warm IV fluids, and again avoid this coagulopathy. And even she has mentioned about therapeutic embolization. See, that is a vital point which the faculty has missed, and madam has picked up. And even in the cervical spine, see, she was bothered about the blood supply to the spinal cord. She was very particular about you have to avoid hypoperfusion. See, that is a key takeaway. So madam has mentioned that is a key takeaway. And see, we are in a separate loop, the speakers, and minimum 800 people will be watching this. And I will post the YouTube link also. I think it will be a permanent record for any postgraduate appearing for exam. Even trauma, I think in the third paper now they are asking a question. It is an extensive coverage. It is an extensive coverage. So I thank all of you, and I request your postgraduates, I will place the QR code also, so they can access all the recordings of this Puthukkottai Bhudhan. All the topics it will come. So far we have covered 34, 18 to go. So subscribe the channel. Actually, what I have seen yesterday only, I have analyzed 75% are coming and watching the thing. Only 25% have subscribed. Once you subscribe, automatically it will reach you whether you like to see it or not. Now what people are doing, they are going to the YouTube channel, they scan the topics, and they pick up the particular topic. And even now I'm wondering, bile separators is the most attended. 1,006 people attended that live. And even after that, most of the people are watching only that bile separators. That means in every college, they are not teaching the basics. They are teaching how to manage this case, that case, this case, that case. But everybody is watching Boyle's apparatus. It is a eye opener. I want all the postgraduates, you please tell them, subscribe. Automatically it will reach whether they want to see or not. They can decide. So once again, I thank one and all, and I request Clearnet to pass their concluding remarks to end the session.
Yes, sir. Sir, I have just checked now. There is no further questions in the chat box. So I'm just, shall I close the session for today now?
Yes.
Okay, sir. So thank you so much everyone for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir.